We have three presenters. The first presenter is Kelly Bos from the Academic Medical Center in Amsterdam, the Netherlands, my home country. And after Kelly, Jacky, Hanson and Alison, Gale will present, and they're both from the Lancashire Teaching Hospital. I got that one right. Sorry about this. But two things. We have the hashtag QFE1 for people who want to tweet about this session, and of course the hashtag Quality 2019. And if anything goes wrong and you need to leave the room before the presentations are over, we have two ways over there to get out, and there's emergency exits that are being with the green lights that are being shown with the green lights. So that's the way to move out of the room should anything happen. That having been said, without further ado, I'd like to invite the first speaker, Kelly Bos, to come on stage.
Prior to every surgical intervention, a checklist is used to ensure that all information needed to safely perform the surgery is known to the whole operating team, and everything necessary for the procedure is in stock. Despite correct use of this checklist, in the Netherlands, 15 patients were operated on the wrong side between 2014 and 2016, and patients then suffer major injury. However, in some cases, patients die as a result of these potentially avoidable injuries, and this potentially avoidable mortality is measured every 4 years. And in the year 2015-2016, it was 1,035 patients. And the impact of sentinel events is enormous. Meet Adrienne Cullen. She's an Irish woman living in the Netherlands, and she experienced some symptoms in 2011 and had a pap smear. In 2013, the results came back and they discovered that she had cancer. So the diagnosis was delayed 2 years. When they found out, they immediately did some additional research. But unfortunately, the cancer was already spread, and they couldn't offer her any curative treatment. Since then, she decided to dedicate her life to fight for awareness until she passed away last December. I am Kelly Bos, and I've worked as a surgical resident for 3.5 years in different hospitals in the Netherlands. And I was professionally involved in a sentinel event. Since 1.5 years, I am writing my PhD thesis on how we learn from sentinel events in healthcare. Of course, I don't do this on my own. I work together, amongst others, but with the Netherlands Federation of University Medical Centers and the Dutch Healthcare Inspectorate. The purpose of this presentation is to inform you about the problems we encounter in the Netherlands, find out if you encounter similar problems in your country and from what country you are, and share our suggestions on how to deal with these problems. In order to achieve quality improvement after a sentinel event, we first need to take a look at the different stages involved. Every stage is equally important, and they're all connected to one another. If you don't report the sentinel events, you cannot analyze them, and if the analysis is of poor quality, then the recommendations will be of poor quality as well. So when one of these stages is neglected, then you cannot expect to have quality improvement after a sentinel event. In the Netherlands, the number of sentinel events reported to the Dutch Healthcare Inspectorate increased over the last couple of years, as well as the quality of the report and the analysis. So we are now therefore focused on the recommendations. Last year, the quality of the recommendations was assessed in Australia following incident analysis, and only 8% was of high quality. What the quality is of the recommendations made in the Netherlands is unclear. Now I would like to share a fictive Sentinel event with you. And we'll be using Slido for this as well. A patient dies due to severe kidney failure after prescribing a nephrotoxic antibiotic in a high dosage. And one of the recommendations made is the case will be discussed within the department. And I would like to ask you to rate the quality of this recommendation. Oh, sorry, yeah. You can open Slido by going to sli.do and enter the code. Code was quality 2019 HAL 5. Okay. Maybe we can see some results. Okay. Overall judgment is this is of poor quality. Okay. I'll get back to you on this. And I will ask you again to assess the quality of this recommendation. But this recommendation actually illustrates a problem we encounter in the Netherlands. We believe not all recommendations following incident analysis are in fact an actual recommendation that seem to lead to a sustainable solution. For example, can we go back to the presentation, please? Thank you. For example, the case will be discussed within the department, or the protocol will be adjusted, or the existing agreements will be reconfirmed. We believe that these kind of recommendations simply cannot lead to sustainable solutions. And I would like to go back to Slido again to ask you the question, do you recognize this problem in your country? And if the answer is yes, from what country are you? Okay. And the next question, from what country you are? Okay, so UK, Denmark, Australia, England. So it seems to be a worldwide problem. Maybe we can go back to the presentation, please. Well, we wanted to create some criteria that a recommendation needs to follow, a so-called filter. So you can only select the actual recommendations in the proposed recommendations. So we developed these criteria based on literature and expert opinion. And the criteria were as follows. First of all, the goal needs to be clear, and the recommendation has to specifically describe what will be adjusted, changed, or replaced. So the protocol will be adjusted is not enough. You need to know exactly what will be changed, so it doesn't happen again in the future. And it also has to reduce the chance of the unwanted event to occur or limit its consequences. For instance, a machine broke down and a patient died, then replacing the machine by a new machine will be a good recommendation. Adjusting the protocol so people will be able to use the machine will be just common sense and is more part of the implementation strategy than just a recommendation. I would like to ask you again to rate this question, to rate the quality of this recommendation. How would you rate it now? Okay, good. Overall, this is not a recommendation. Yeah, the answer should be this is not a recommendation because it's unclear how it will prevent the sentinel event from occurring again. Well, we decided to test this filter, so the 3 criteria we made, and 3 medical doctors who are familiar in handling sentinel events assessed or selected 10 sentinel events and their following recommendations, and they individually used the criteria to select recommendations, and the results were discussed afterwards. Only 45% of all recommendations were actual recommendations. So more than half of the formulated recommendations aren't really, well, they don't meet the criteria, so they aren't really recommendations you can expect to lead to sustainable solutions beforehand. So it could be that currently we spend time, money and effort on on recommendations that simply cannot lead to sustainable solutions. We also wanted to assess the quality of the remaining recommendations, so the recommendations that passed the filter. And as the quality of the recommendations in the Netherlands remains unclear, therefore we performed a systematic review to identify methods to do so. And we've identified 11 methods that can all be used to select and discuss the recommendations and select them for implementation. However, many methods were based on subjective assessment. For example, they used a 1 to 5 or a 1 to 10 scale, and discussing why I think a recommendation feels like a 7 may therefore be difficult. Also, some methods were not user-friendly as they used a lot of complicated calculations in order to get a prioritization, and only one was validated. And these were actually all aspects we wanted in our model to assess the recommendations in the Netherlands. So we discussed all these methods in an expert meeting and used aspects of 4 of them to develop a new model that would fit our criteria. So assessment based on objective features, user-friendly and validated. And we came up with this model. It's a square, and first you need to determine whether a recommendation intervenes before or after the unwanted event. In theory, a recommendation that intervenes before the unwanted event is better than a recommendation that intervenes after an unwanted event. Secondly, you need to determine whether a recommendation eliminates the source or controls the source. Again, elimination of the source is better than controlling the source. So then a recommendation can be put in one of the 4 quadrants, and then you can decide in what category it can be placed. So for example, a recommendation will be placed in the left upper quadrant. Then you need to determine whether it can be placed in the category elimination or replacement, and elimination is better than replacement. So you can put them right in the model. Let's take another look at another recommendation following the previously mentioned sentinel event. So again, a patient dies due to severe kidney failure after prescribing a nephrotoxic antibiotic in a high dosage. And now the recommendation is send every resident a list of all nephrotoxic antibiotics. And the question for you is now again, through Slido, where in the model would you place this recommendation? Maybe we need to go back to the model once again. Okay, so administrative procedures on the right is the overall assessment. I think it's maybe administrative procedures on the left side because it aims at informing the residents and making sure that they are aware of the dangers of prescribing nephrotoxic antibiotics and intervene before kidney failure. So maybe it's a benefit of the doubt idea, but this is a little bit how we discussed the remaining recommendations, or the recommendations that did pass the filter. Can we go back to the presentation? Thank you. So again, it could be in the administrative procedures on the left or the right side, depending on how you look at it, but I think benefit of the doubt. So to test the model, we placed the remaining recommendations, the recommendations that did pass the filter, individually in the model, and discussed the results afterwards. And the overall quality was as follows. Also, 3 medical doctors and 4 inspectors of the Dutch Healthcare Inspectorate assessed the quality of the recommendations individually. We had 9 sentinel events and 17 recommendations, and 53% was directly placed in the same category. Almost half was not, so we didn't agree a lot. And we were, during discussion, we only used the unwanted events and the recommendations. And during the discussion, we discussed why a different place was selected, and the recommendations could be interpreted differently from one another. But when we considered each other's perspective, then we put the recommendations in the same place. So we feel like the model works. And we think that the people who will be working with the model, so the people in the analyzing teams in hospitals, that they don't have this problem because they have access to the whole report, and they can discuss with colleagues how everything really went, instead of just looking at the unwanted events and the recommendations. So the overall quality of the remaining 17 recommendations were this. So the quality isn't really that bad. It could be that currently, again, we are spending time, money, and effort on relatively low quality recommendations, or on recommendations that don't pass the filter, as I mentioned earlier. In order to reduce similar sentinel events, we need to focus on implementing just the high quality recommendations. However, so the quality of the recommendations, of the existing recommendations, can be assessed using this model, but we can also use the model to increase the quality during formulating the recommendations. Imagine the patient with a severe kidney failure again. So the best recommendation will intervene before the unwanted event and eliminate the source, and will be in the category elimination. So we could say we eliminate working with nephrotoxic antibiotics, or we can replace them. However, other people might die due to severe infections that cannot be treated with other antibiotics. So maybe in this case, we need to go to a recommendation in the category control, and control is usually a technical control. So we can build in a technical control to, for example, in the system. So when you prescribe nephrotoxic antibiotics, you can only prescribe 1 or 2 dosages, and then you need to fill in a new kidney function in order to continue treatment in an adjusted dosage. However, please explore these high quality recommendations, maybe in collaboration with other hospitals, because exploring these could lead to very sustainable solutions as you work together. But to summarize, a recommendation really needs to fit the criteria of a recommendation, and when it passes that filter, the model can give insight in the quality of the recommendations in a more objective manner than the manners we found earlier, and therefore contributes, in our opinion, in selecting and prioritizing the high quality recommendations for implementations. Also, working with the model will give insight in formulating recommendations differently, so the overall quality increases. So we are now focused on increasing the learning capacity by increasing the quality of the recommendations, but in the future we can also consider the other stages of quality improvement, like implementing the recommendations and monitoring their effect. However, aspects like culture and human factors, which are not embedded in our model, also need attention in order to make healthcare better and safer in the future. And Alison and Jacky will tell you something more about human factors. So I'd like to thank you.
Super, Kelly. Thank you very much. Yeah, you can. Okay. I'm very proud of your performance. Isn't it great that young PhD students can stand up here in a hall that can seat 3,000 people, but you only see the front row, and give such an excellent presentation. That's the future of the forum right there for you. Okay, the next presenters, Jacky, Hanson, and Alison, Gale. Can I invite you to the stage?
We're delighted to be able to present a piece of work that we've done in Lancashire to you today, which is in the northwest of England. My name's Alison, Gale. I'm a consultant obstetrician and gynaecologist at Lancashire Teaching Hospitals, and I work with Jacky, Hanson, our Director of Simulation, and Mike Davis, who's a medical educationalist. So the work involves human factor training, and I'm delighted to be able to share the findings of it and raise the profile of human factors as a cause of medical error.
Sit next to the Alison. Use the mic, I think.
We used monies from the Health Education England Maternity Training Safety Fund to fund the work we've done here. Is that better? Sorry, I thought I was wired up, but obviously not. For those of you that don't know, Health Education England at the back end of 2017 gave funding to all maternity units in England to try and upskill the maternity healthcare workers with the aim to deliver multi-professional training to improve the safety of care of mothers and their babies, okay, in England. It was one-off funding that was delivered, and the work had to be completed within 12 months. So that's the funding we used to deliver this project. The messages I hope to be able to show you over the next 20 minutes or so is that you can provide a successful educational intervention in human factors. There was great enthusiasm from all the staff we trained that not only was the training worthwhile and had benefit, but it should be rolled out to the entire maternity healthcare workforce. We were able to identify improvements in individual human factors, and we also highlighted that there is a huge cultural challenge within maternity services to embed some of the work and the human factors into the day-to-day functioning of maternity units in the United Kingdom. To give you a little bit of background, we know from data that's widely published and reports that are published that 1 in 10 patients in England, in the United Kingdom, come to harm from their inpatient stay. Okay, and figures are similar throughout the world, especially in developed countries. We also know that 70% of those cases are contributed by human factors and human error, and I mean by that both individual non-technical skills, but also system analysis and system failures. Okay. The slide that I've shown here is a little piece from a piece of work called Each Baby Counts, that if there are obstetricians and midwives in the audience will be aware of what that is. But that's a project that was initiated by the Royal College of Obstetricians and Gynaecologists in 2015 with the aim of identifying all babies that either died during labour or suffered severe disability as a result of labour, of particular incidents that happened within the labour process. It concentrated on term deliveries, so not the premature infants that we know have an increased risk of problems. And the aim of the project was to look at every single case in the United Kingdom over a 5-year period. And the data that they published recently is the data for the 2015 cohort. There were about 580 stillbirths and episodes of hypoxic ischemic encephalopathy identified. And the data that I show on the slide demonstrates that human factors were implicated in the majority of the cases. And if you look a little bit at it, you can see that individual human factors were implicated in 53% of cases. The majority of those were from situational awareness, but also brought in team working, leadership, and some cases that was due to stress and fatigue of the people involved as well. And also 57% of the cases implicated communication failures, the majority of those being either between teams, professional teams, or within professional teams. So as a result of wanting to do something to improve the situation in the northwest of England for safety and maternity care, we developed a consortium, what we call the Better Training, Better Birth Consortium, which was a consortium of trusts within our local maternity service, which was the whole of Lancashire and Cumbria. 3 of the trusts, 3 of the large teaching hospitals participated in the consortium, and we developed a 2-pronged approach to try and improve both practical, hands-on clinical skills in obstetrics, and also delivered a bespoke human factor training package to senior healthcare workers in maternity. The practical obstetric skills that were covered were things that we were already covering, but we improved the programme to cover the list that is on the left. And in the bespoke human factors training, we covered both non-technical skills, i.e. communication, situational awareness, decision-making, leadership and teamwork. And we also covered the wider human factors, both systems analysis, where not only did we teach them how to analyse systems, but we gave them a tool to help them when they looked at root cause analysis and incidents in their workplaces. We looked at medical error and human error, and we gave them tuition both in stress and the effects of stress, and the effects of fatigue, and we gave them some resilience training as well to improve their personal well-being. The next 2 slides, I just want to talk briefly about the obstetric skills training, and then we'll concentrate for the rest of the session on human factors. But the aim of the first arm of the project was to standardise the obstetric skills drill training that we were delivering across the trusts within the local maternity service. So we changed the system to deliver the theoretical content by e-learning, and all the trusts that were involved utilised a system called K2, which is a perinatal training programme that's available throughout the UK, probably nationwide as well, worldwide as well. And then after that, we changed the skills drills programme to put all members of the multi-professional teams, so from the healthcare assistant through all the midwives, all the obstetricians, all the anaesthetists, through hands-on skills training to manage those obstetric emergencies. And rather than try and deliver all 7 emergencies on one day, we made it a 3-year rolling programme so that every healthcare provider in maternity would be trained in all of those emergencies over a 3-year period. Initial outcomes from the change in the system to deliver the skills drill training were very favourable. The people involved in the training far preferred it to the previous system, and they particularly enjoyed the interaction that it gave them with staff from other units, enabling them to share experiences and practice. There were many incidental positives from changing the system and the work that was done. Probably the biggest of these was the development of our practice development midwives and the network they managed to produce, not only to aid collaborative working between the trusts within our service, but also to share guidelines, and it also gave individual trusts a way of benchmarking their practice, both in these areas and other areas of practice as well. I now want to move on to the human factors training we delivered, and rather than buying a product off the shelf that was out there, we wrote, developed and delivered a bespoke human factors package that took about 6 months of writing. We then delivered it over a 6-month period between January 2018 and June 2018. We developed it as a 2-day course, whereas the first day we were concentrating on non-technical skills. So we had interactive lectures and workshops on communication, on situational awareness, decision-making, team working, leadership and followership. And we wrote our own case studies to aid some of the discussions that we had. The second day we concentrated on systems analysis, using this tool to aid them when they were looking at their serious untoward incidents and how to assess them. We looked at medical error and human error, and we spent some time on the effects of stress in the workplace and how to build a more resilient workforce from an individual point of view, helping them with their personal well-being. The course we delivered 5 times, so the 2-day course 5 times, and we delivered it to all senior members of the workforces, the multi-professional workforces in the 3 trusts that were involved. So that involved consultant obstetricians, consultant obstetric anaesthetists, and all the Band 7 midwives and matrons across the 3 sites. So it amounted to just over 100 people we trained in that 6-month period, with the aim that they would take the work back to their workplaces and disseminate it to other members of staff. When we did the work, we mixed the teams from the trusts and we mixed the teams from the professional backgrounds as well. So on individual tables, for example, we'd have a consultant obstetrician from one trust, a consultant anaesthetist from another trust, and Band 7 midwives and matrons from a 3rd trust. Okay. And we mixed the day 1 and the day 2 to encourage people to go to other trusts to attend the training. And we obviously deliver the training in 3 different trusts rather than just sitting where we work. Sorry, this is a bit sticky. To evaluate the work, we used an expanded version of Kirkpatrick's hierarchy that you will be familiar with. The first 4 levels are Kirkpatrick's traditional hierarchy, but the higher levels we've used and added to try and reach a higher level of analysis of the work that we've done. You'll know that the lower levels of Kirkpatrick's hierarchy are actually very easy to collect data on. However, the higher you go up the pyramid, the more difficult that becomes, the more time-consuming it becomes, and the more difficult it is to tease individual factors out and to know how much a single intervention, for example our educational intervention, has on the impact of changing behaviour and changing patient outcome. Okay. Because of that, our evaluation strategy covered 3 points. We did run post-course evaluation questionnaires and surveys on the days of the training. And then following that, we invited all participants to write reflective accounts of what they'd learned and how it had changed their practice. And finally, several months after the educational intervention, we invited the participants to attend semi-structured focus groups where we explored the impact and effect the educational intervention had on them. I now want to hand over to Jacky, who will discuss some of the results with you. It's a bit sticky.
Thank you. Just to introduce, Mike Davis is the 3rd person up here, and he was the gentleman who's a consultant in medical education and was the one that we worked closely, very closely with regarding the educational evaluation. We first, when they first arrived on the first day of each of the different groups that we had, we decided that we needed to get some baseline attitudes towards the human factor issues. And it was interesting to find out when we posed these questions to them that the delegates did claim a quite significant familiarity with human factors. However, they were very, very keen to have human factor training, more training, and seemed to feel that it was an incredibly valuable intervention. It was also interesting that as we went through the training, we actually noticed as a faculty that perhaps they were a little bit less aware of non-technical skills and human factors and ergonomics issues than they actually claimed. And this is actually part of what's, or demonstrates what's known as the sort of Dunning-Kruger effect, in which people are overly favourable of their views of their social knowledge and skills, abilities. And the other aspect we looked at was team working, and we asked if they had any concerns about working within their teams. And they said they had no concerns working with colleagues within their teams, which is interesting with what comes up in the future. Afterwards, the post-course evaluation, in each day we asked about regarding how much the extent of the course was met their particular needs for regarding human factor training. And it was noticed that there were very high levels of satisfaction with the presentation and also the content of these interactive workshops, using videos for examples, which was particularly poignant and seemed to get the point over quite well, and particularly some of the national videos that we've got, particularly there's one from Leicester called TED. And we also utilised, in the human factor analysis, we used case reports. So we actually presented the cases to them and worked through them with the model that we were using for human factor analysis of error. Very good evaluation, as you can see, across the 2 days, and the open responses showed and highlighted that the key issues that they felt that they'd learned a lot about was human factor analysis, particularly when it comes to systems, because normally when you obviously appreciate, and as the previous presenter alluded to, we're not quite good at these recommendations when it comes to looking at and analysing our sentinel events or serious untoward incidents. And one of the aspects with this was to take it further, to look at a particular event, look at the timeline, and look at the different types of human factor problems that can occur at different points throughout that event. And that was actually using something called the sheep model, which is actually from Debbie Rosenhorn-Lang, and that incorporates systems, human activity. It also includes environment and also equipment, as well as personal problems. So it's actually quite useful and gives people, or the tool gives them something to enable them to explain things. The other aspects was that they were keen on was resilience. They were really keen on well-being of the individual and how within that stressful environment they worked, and the increasing work that they've got and the stress that's involved with that and the fatigue, how they can help themselves with resilience, either at work or outside work. And it's interesting as well, after what happened with the sort of baseline, was that their understanding of human factors and the challenges with human factors actually improved, and they understood a lot more about it. What was the next most pressing steps we felt we should ask them? And the resounding thing that came over was that they felt, as Alison alluded to, that this was just seniors that we taught initially, that it should be rolled out to everybody, certainly in the maternity services, but basically everybody on the whole of the trust, or all the trusts. But initially in maternity, they want it rolling out to the Band 6s, midwives, and also to the trainees in obstetrics. Again, it was interesting that from what the initial baseline was, that the comments on teamwork and motivation, and the fact that they felt that their team, they could actually improve teamwork with their communication and the tips that they got about it and motivate the team better. Also, they felt that they could improve handover and communication within handover. Definitely, a lot of them said that the reflection and their personal learning would be helpful to improve, but we'll come on to that in the next assessment. And resilience was another key thing, their well-being. The challenges to that implementation of change again came up, which in fact is something that we've been talking about earlier on today and throughout these the couple of days, is culture. And when we found out from the post-course evaluation, they were concerned that the culture change would be extremely difficult in the NHS. And in fact, they said particularly in the maternity setting, for example, in labour ward. Was also interested about, again, implementing change and changing people's thoughts processes. So again, it was about culture and about how we change the way people behave with each other. Again, they wanted here to encourage their own individual personal reflection and self-awareness. But again, they felt that that was difficult because of time factors. And the other thing about challenges to change is obviously timing, or the time factor, and staffing within the departments. When we look at the reflective accounts, there was minimal engagement to this, which comes back to the fact of the previous slide that they felt that there wasn't enough time for this reflection and time for personal sitting down and thinking about what had happened that day. And I think that what tends to happen is that what most people, when you talk to people, and certainly some of the semi-structured interviews showed this, that a lot of people do their reflection on the drive home. They tend not to write it down. And there are a lot of time they don't have time to, because once they get home or when they're in work, they're too busy. They haven't got that time factor to be able to sit and think about things and reflect on what's actually happened. Because often when you get home, life takes over, there's busy, we all have busy lives. There was certainly an expression of enthusiasm for human factor training across the board. And it was interesting that there was a couple of reflective things about the clinical environment, and they were at least able to utilize human factors failings. They were able to describe it and have the language to describe those human factor failings in their clinical environment. But there was really no next step for the impact on practice. However, when you look at the semi-structured interviews, it was interesting that there was obviously a little bit of change in their clinical practice, but they hadn't realized it. But it was a specific changes to their non-technical skills. And what was happening was that they were actually improving their pattern of communication. The tips that we allowed them in their communication workshop to be able to demonstrate and think about, they'd started to improve their patterns of communication. It was interesting also that even though they'd said that they were quite happy with the way the teams worked, they felt that their teamwork was enhanced by the enhanced communication and being able to move from that sort of noisy, messy, sort of unstructured way of talking to each other when they're in a team to something that felt a little bit more psychologically safe. There was also an improvement within the leadership area in the fact that they felt it was more flexible, more fluid, particularly in the labour wards. And the key thing that I think that they learnt was that they had permission to hand over. In other words, if they became task focused, if they had to go in and see a lady within one of the cubicles, when they were leading, they could hand over leadership without fear of worry about that, because everybody knew that that was perfectly reasonable to do that. And then when they'd finished a task, particular specific task focus, they could come back out again and actually hand over leadership, have a handover of leadership. And the safety huddles, the importance of those safety huddles that they've been doing was much more evident. So the general overview from the semi-structured interviews was certainly, there was a high level endorsement of satisfaction with the course and the fact of the understanding that they felt that they obtained from human factors and the training from the workshops and the videos, and also from the human factor systems analysis. The key thing was that they wanted it rolled out to the rest of the junior trainees. And it was interesting, actually, they actually asked that myself and my colleagues do all of the training. Well, there's about 500 Band 6 midwives, so I think that we might have to be training some further trainers as well to do that. But it's important to roll out the training to all the Band 6s and also the trainees, and we have actually done the training for the ST3 to 5s in the region. And the other big challenge was the challenge of changing the culture, because the culture was felt to be difficult to change, or maybe even dismissive of change, which was an interesting concept that somebody had come up with. So in summary, the key messages, as Alison showed at the beginning, was that it was a successful educational intervention, teaching people about human factors and ergonomics, as well as and including those non-technical skills. but giving them more awareness and a language of being able to understand what happens in systems, understanding about violation, transgression, migration, all those things that come around with systems and system error. And there was a definite enthusiasm for rolling out of the project to all staff, and there were some people that did volunteer to become trainers, which will be our next step in the programme. There was an identification of some improvement in non-technical skills, particularly with communication and team working and leadership. But the real challenge they felt was that of culture change. And I think the more people we teach, maybe the cultural change will come with that. Thank you.